are aware that COVID-19 has presented its own challenges, but it's even worse when it comes to SRHR issues. And therefore, today we are having this conversation or this dialogue to highlight or commemorate the Day of Safe and Legal Abortion. Those of you who are not aware, that happened yesterday. And so we will be bringing you up to speed on what that is about and what the situation is like in Uganda. And we will also be listening to a few amazing stories from the different people that have lived and experienced the realities of the effects of COVID-19, but also the effects on access to SRHR. So right now I want to invite us to watch a video or two on some of the experiences of the women, and then we'll call us back to a space where we have the actual conversation.
Naye twalina anko waffe ng'ali naffe nga tabeerako wala naffe. Ku lunaku lumu mami wange yetaliiwo nga batambuddemu nga bagenze bonna nga nsigaddewo nzekka ewaka. Oyo anko wange n'ajja ewaka n'atandika okuŋŋamba ebigambo n'aŋŋamba nga wendi omulungi wenfaananamu wange ne mbuuza anko ebyo lwaki byonna obiŋŋamba ate oli anko wange. N'aŋŋamba oli mukulu olinganga atamanyi kyentegeeza. Ne mugamba nze sibimanyi n'eŋŋaana. Then nanforcinga ng'ayagala havinga sex nange olw'amaana nankwata neera n'alemerako nankwata. Naye nagambako mami wange n'aŋŋamba nti nonsirike nga tayagala kuswaza famire yaffe. N'aŋŋamba mbu wekinatuuka mu bantu famire ye ejja kuswala nnyo. N'ensirika naye saafuna buyambi yadde. Nagenda okumaliriza nga nfunye olubuto ne mbuzaako mikwano gyange ekyokukola. Ne bandagirira waliwo gye bandagirira omukyalo omu ne nkola abortion olubuto ne baluggyamu. Naye nabreedinga nnyo kubanga saafuna buyambi bw'amaanyi. Teri yali akimanyi okuleka mami wange ne mami wange saamugambako nti n'olubuto nduggyeemu. Ne nduggyamu bampa eddagala biri awo tebitegeereka. Kuba omulanga eri bonna bekikwatako batreatire oba ebintu ebisobola otuyamba oba abantu tetusobola okgenda nga tufunye obuzibu ng'obwange bwe nafuna nti naye weputi naye saafuna buyambi bwonna. Nasirika busirisi nenkola abortion etali ntuufu katanfirwe n'obulamu bwange. N'abawala abalala bangi bafuna obuzibu ng'ebyo naye tebafuna buyambi. Bangi bafiiridde obulamu bwabwe kubanga nakirabira ku nze kata nange nfe. Na breedinga nnyo navaamu omusaayi mungi. N'enkoga yali asoma takyasoma. Ne sitasobola kuddayo ku ssomero. Nefiirwa ebintu bingi.
From watching that video, I hope that some of us are ready for the stories that are going to be shared here, and we apologize for those who are very sensitive to the content that's going to be shared today, or for whom this information that we're sharing today might be a trigger. We deeply apologize, but we also resonate with you, and that's why we are having this conversation to highlight a few of these things. The purpose of this dialogue today is, one, to share the lived realities of women during COVID-19, but also find ways of mitigating the effects or the challenges that women have gone through during COVID-19 in relation to SRHR and access to SRHR services. And before we get into so much talk, I would like to invite our keynote speaker for today, who's going to give us a national perspective, a big perspective on why we are having this conversation, what we should look out for, and a few recommendations that will set us on a pace to have a panel discussion, and then after the panel discussion, we will invite you to share your questions. For those of you who are watching us online, you can start sending in your questions even as we proceed, so that we can ask those questions to the different people that will be speaking today. And for our keynote address today, we have Miss Rose Wachikona. She's the Senior Program Officer at CHAD, that is Center for Human Rights and for Health and Human Rights in Development. She's a feminist and also a Christian. Yes, some of us think you cannot be a feminist and also be a Christian. We have an example here live. She's a feminist, she's a Christian, but she's also a lawyer. Welcome with me, Miss Rose, to share a keynote address with us.
Thank you so much, Penny. I am very happy to be here to present this keynote address. And for all those kind words that you have said, all that she has said, I am, and I am so much more than even that. So for those who want to know so much more, please reach out to me. This keynote address was supposed to be delivered by Dr. Olive Sentumbwe, by Mugisha from WHO, but she trusted me and gave me this big responsibility to step in her shoes and actually do what she was supposed to do, but I hope I can fulfill. So the heading or the title for our address today is the not so visible SRHR conditions within Uganda. Many times we talk about the visible sexual reproductive health challenges within the country, and we shall highlight maternal mortality, HIV, access to contraceptives are some of the visible issues, access to health care, but there are some not so visible issues which make very many of us very uncomfortable. And today we've come to discuss those issues. Those issues are leading to the death of so many women. And not just women, but even men are dying because we have chose to make them invisible. Today we want to make them visible and give a voice to those people who feel that society has cast them aside, has put them in a place where they cannot operate within the mainstream. And these are the issues that we are going to discuss today. Following the keynote address, we shall look at the HIV status within the country as per 2019. When you look at the HIV status as of close of 2019, we have 1.5 million people who are living with HIV, and young women and girls are disproportionately affected by this. We have 5.8% adult HIV prevalence rate, and these are people who are between the ages of 15 and 49. We have 53,000 new HIV infections that occur annually every single year within the country. We also have 21,000 HIV AIDS related deaths within the country. Right now, COVID stands at about 63 people, but HIV already within the year has killed 53,000 people within the year only. 85% of adults with HIV are on antiviral treatment, and 65% of children on ARVs have a problem with access to the ARVs that they are supposed to take. When we go down and look at another invisible issue, we have the status of abortion within the country. Abortion is one of the very invisible issues within the country. We all know that there are over 800 abortions that happen every single day within the country. But this is something that is not talked about. It's something that is not mentioned. Worldwide, we have over 25 million unsafe abortions that happen. 45% of all these abortions are unsafe, which means they happen using crude methods. We are talking about things like hangers being poked into the cervix. We are talking about people taking jig, omo, all these things in order to expel a fetus, or even using traditional herbs that are being promoted. Or even right now we have an increase in the quack doctors. You'll see posters being put on the parliament, even on different hospitals, that people can provide safe abortions, but when they are not trained health service providers. We also know that the majority of unsafe abortions, that is up to 97% of them, occur in developing countries. Here we are looking at Africa, we are looking at Asia and Latin America. And the thing that these places have in common is the fact that they have restrictive laws and policies on abortion. when we look at the key facts that affect abortion in the world over, we know that between 2015 and 2019, there was an average of 73.3 million induced abortions, both safe and unsafe, which occurred within the world just between those 3 years. We also know that 3 out of every 4 abortions that occurred in Africa and Latin America were unsafe, and they led to the death of many of the women, but also to a lot of morbidity. We also know that around 7 million women are admitted to hospitals every year in developing countries as a result of unsafe abortions in order to access post-abortion care. This is a challenge that we need to radically address as a country. So what do we mean by a safe abortion? What do we mean by an unsafe abortion? A safe abortion is one which is carried out as per the WHO guidelines and recommendations, and that is usually with the help or with the assistance of a skilled healthcare provider. But because of the restricted laws that we face within this country, we find that most women cannot access a skilled healthcare provider because the law prevents them from accessing them. We also know that when an abortion is unsafe, it is carried out by either a person who is lacking the necessary skill or in an environment which is unsafe. So here we are looking at an environment which is maybe late in the night, in a dingy place, which is dirty, with unsterilized materials. We also know that the people, skills, and medical standards considered safe in the provision of induced abortions are different for medical abortion, which is provided by only drugs. So the skills and medical standards required for safe abortion vary depending upon the duration of the pregnancy and also the evolving scientific advances. Women, including adolescents with unwanted pregnancies, often resort to unsafe abortions when they cannot access safe abortion services. This means that we are putting in place barriers that make it impossible for them to access the services that we need. And this is caused, some of these barriers include the restricted laws and policies that we have, also the poor availability of services. You find that many health workers are not willing and ready to offer the service. We also have a very high cost for abortion care within the country, which has made it a preserve of the rich. If you have the money, you can go into a private health facility and access the service. But if you don't have the money, you have to resort to unsafe means. There is also a lot of stigma that is attached to abortion for people who both provide it and who seek the service. We also have the fact that there is conscientious objection for healthcare providers who stay away from even providing emergency services like post-abortion care, and unnecessary mandatory requirements such as waiting periods, getting permission from 2 doctors before you can access a safe abortion, and etc., which act as barriers. So almost what this has resulted into is that 44% of the pregnancies that occur in Uganda are unplanned. And many of them will have this question of, should I terminate or should I not terminate? But they are not given an opportunity to come before a health worker and have this conversation in a candid way, majorly because of our restrictive laws. We also have a low contraceptive prevalence rate of 39% in Uganda, which means that we have an unmet need of 28% for family planning. Those who need the family planning cannot access it. Even when they cannot access it, they have limited choices. You go to a public health facility and find you have only maybe 2 choices of a contraceptive. And if you react adversely to it, then there is nothing for you to do. You have to get off it and perhaps end up with an unintended pregnancies. So what we know world over is that we need to have access to treatment. We need to have access to health care services. This means that health care providers are obligated to provide life-saving medical care to any woman who suffers abortion-related complications. In our laws within the country, we know very well that post-abortion care is legal, but health workers are even stopping themselves from providing the post-abortion care as is needed. But even the government within itself is not providing the necessary medication that women may need to be able to access post-abortion care. We also know that the practice of extracting confessions from women seeking emergency medical care as a result of illegal abortions puts them at risk because they will stay away from health care facilities, because they know as soon as I enter into that healthcare facility, they are going to force me to say how I started it, when I started it, who gave me the drugs, and they also put an undue burden on healthcare workers to be able to disclose and breach patient-client confidentiality. So how can we stop or prevent unsafe abortions? We can do this through comprehensive sexuality education. Girls and women need to be taught how their bodies work, what they need to do to prevent pregnancies, and what they need to do when they end up with an unintended pregnancy. We need to have comprehensive sexuality education. Right now we have a national sexuality education framework which is in the pipeline. It has been made by the Ministry of Education, but rolling it out has now even become difficult because schools have closed due to COVID-19, which means that out of school is what is supposed to work, but we have no guidance for out of school sexuality education. We also can prevent it through the use of effective contraception, including emergency contraception services. This means that the government needs to prioritize the purchase and the dissemination of contraception within all public health care facilities. But we also need to provide safe and legal abortion services within the country by decriminalizing abortion within itself, but also by making it safe for women to access the services. In addition, we also need to put statistics to unsafe abortion within the country and make it an evidence-based approach issue. When we go down to another issue that has been made invisible, we have gender-based violence, especially during the COVID-19 pandemic. We have seen over 6,300 cases of sexual violence being reported involving girls and young women, both for intimate partner violence, but also for sexual violence within itself. Many young girls and women, both in Kampala and other parts of Uganda, have suffered both mental and physical or domestic violence, as well as economic violence. We have no reported cases of marital rape. First of all, because it's not recognized within this country as an offense that you can rape your wife. So they are not documented. But even then, even if it was recognized in our law, are women going to report their husbands that they raped them yesterday? That is the question we have to ask ourselves. Then we also have an issue of corrective rape within the country, where you'll find trans women or queer women being thrown in jails together with men, and they are being raped in order to correct them and set them back on what is socially acceptable. But we have no data concerning this because we have made their issues invisible, we have trivialized their pain, we have trivialized their problems, and we have relegated them to the outcasts of society. So if we do not begin as a country to collect the correct data so that we can build the right evidence and make the correct interventions, then we are not going to have an end to all of this. We have sexuality education, which I already talked about just a little bit originally. But again, when I come back to it, the government of Uganda has made strides in trying to roll out sexuality education. They have come up with the framework, which we upload them for. But right now, it's about the implementation of the framework. How are we going to implement this framework within this country when all the children are at home? Have the parents, has there been a suitable parent program that has been developed in order to help parents to disseminate sexuality education? Many of the time when you switch on your television, you see them teaching math, you see them teaching biology, you see them teaching English, but you won't see them teaching sexuality education. But we know very well that children are at home having sex. So why are we not giving them the age-appropriate information that they need in order to address this problem? When we go to LGBTQ issues, we have trivialized them as a country. We think they do not exist, but they are among us, and they are with us within this country. They are people too. And even as we come today within this country, we shall take an international survey because, again, within as a country, we do not have statistics to just quantify and put a face to them. We know that 12% of the people who identify as LGBTQ people have HIV, and 16% did not know their status. This is because they cannot go to health facilities in order to access the testing that they need and the treatment that they need. Of those, a vast majority are on HIV treatment. Although 72% said they had no interruptions to HIV treatment, 21% said that their access had been limited or complicated, with 7% saying that they either had to or were in imminent risk of running out of ARVs. This is something that we have seen reported even in media reports. People were not accessing their ARVs in time. We also know that 42% of the said they had 1 month or less of medication left, and yet we cannot have interrupted supply when it comes to HIV/AIDS. So in terms of their economic position, for people who are identified as LGBTQ, 13% of respondents said that they had lost their jobs as a result of the COVID-19 lockdown. 21% said they felt at risk of losing their jobs, and 23% said they felt insecure about their employment. Food insecurity was also frequently reported, and 23% said they were eating less or had skipped meals because they had no access to food. We also know that they have a higher risk of infection for HIV/AIDS. While 1% said they had actually started doing sex work because of poverty and lockdown issues. So these are people who need to be looked into, and interventions need to be designed in order to handle their particular issues. So what about family planning? Family planning is another issue that the burden has been placed on women to control fertility. Men are not participating, men are not engaging. The call today is for men to come on board, to participate, to engage, and know that family planning is not the preserve or the prerogative of a woman, but it's supposed to be a shared responsibility between a couple. So it is expected that because of COVID-19, the unmet need for modern contraception is going to grow by 20%, from 218 million to 267 million are going to need contraceptives, and they are not going to find it. This we are already seeing in the stock status reports of the Ministry of Health as per 1st August 2020. They already reported a stock out of sexual reproductive health commodities. So this within itself is a challenge. It means we are not getting the commodities within the country. We also have another invisible issue, which is cervical cancer. Cervical cancer happens because majorly of early sexual debut. We know that in Uganda, the earliest sexual debut or the average sexual debut for most people is 14 years of age. So if people are having sex at 14 years of age but cannot access healthcare services as and when they need it, the likelihood of them getting cervical cancer is very high in the near future. So we are dealing with different epidemics. We are dealing with an epidemic of teenage pregnancies. We are dealing with an epidemic of unsafe abortions, but we are also dealing with an epidemic of cervical cancer, which is on the rise. And Uganda, as can be seen from that chart, has one of the highest levels of cervical cancer within the country. So until we begin to deal with the early sexual debut and the teenage pregnancies and the child marriage and issues surrounding early sexual debut, we are not going to be able to deal with the cervical cancer epidemic. How we can address this, of course, number one is HPV immunization. We have to scale it up. We have to delay sexual contact, and this is by aggressively teaching children what they need to do with their bodies. What is the conclusion from all this? Going forward, we have our challenges. We have very many challenges as a nation. We have very many challenges as a country. But this gives us an opportunity to design programs that are good for us, programs that work for us. And this is something that we need to look into as a country. How do we improve on the damning statistics that have been shared? But also we must begin to build bridges of understanding between people people who do not look like us, people who don't sound like us, people who identify differently. Instead of pushing them to the fringes of society and othering them and making them feel invisible and voiceless, why don't we bring them to the table and talk without them fearing that they are going to end up in jail? Why don't we stop trivializing their voices? Why don't we amplify what they have to say and listen to them diligently and quietly and love on them as a country? We also need to do more, a lot, to ensure that women and young people access the services that they need. Within Kampala alone, we have only Naguru Teenage Health Center to serve all the youth of Kampala. That is where they can be able to access youth-friendly services. Anywhere else, you have to pay money because it would be a private health facility. What can we do as a population which is younger and younger by the day? What are we going to do to address the SRHR challenges? These are questions that I throw back to us. Again, we need to engage more with the men because they seem to think that sexual reproductive health is a preserve for women. I don't know why. Is it because women have uteruses and men don't? That is a question we need to ask ourselves. But we need to know that sexual reproductive health is a joint responsibility between a man and a woman, because ultimately when a child is conceived and born, they have the DNA, half their father, half their mother. It is not 90% the mother, 10% the father. So men need to come on board. We need to discuss and have these issues made out. Thank you so much for listening to me.
Thank you so much, Rose. Wow. First, I want to congratulate all of you for surviving the different pandemics that we are dealing with, because I am already just overwhelmed hearing the numbers and the figures and the statistics. And some of us are not even keen on the statistics, but maybe the stories will make us wake up a bit more. I am glad that the keynote address invites men to participate a bit more. That for me is a big thing, that men should participate a bit more in the conversation on SRHR. And some of us are very, very eager to participate in the visible issues on SRHR. We are quick to say, yes, I am for menstruation. Let's talk about menstruation. Let's talk about the things that we're comfortable with. But there are things we are not comfortable with, and these things are happening around us. It is very sad that annually 297,000 women forcefully abort. That's sad. That is sad. So before I invite our panel to take us through a deep conversation to analyze this data that the keynote put before us and the statistics there are, let us watch a video of a story of a girl that has undergone, that has experienced abortion, and let's see what that means for our conversation going forward.
Naina mukwano gwange ng'amuyita Sise. Sise yalina emyaka 13 nga yafumisibwa olubuto mulenzi gwe yali asoma naye. Sise nga olw'okutya okungi, Sise nga afuna ekirowoozo ky'okulugyamu kubanga yali atya bazadde be. Kati ng'abaako mukwano gwe gw'abuulira, mukwano gwe ng'amuwa amagezi nti addeyo ewaka, kwate seppiki ateekemu soda kooko amutokose amunywe, olumala okunywa yeebikke. Ebintu byagize bijja kuvaayo byokka. Kati Sise ng'anywa soda nga bwe baali bamulagidde, Sise nga yagenda yeebaka. Okukeera ku makya ng'ebintu byavuddeyo, naye olw'obutamanya mwali mwasigalamu akantu. Sise ng'atandika kulwala, Sise ng'alwala, Sise okumutwala mu ddwaliro. Abasawo bategeeza abazadde be nti yaggyamu olubuto naye ne musigalamuuko ekitole. Asawo okugezaako okujjanjaba Sise, Sise ng'afa. Olw'okubanga Sise yali tamanyi nawa waayinza kujja buyambi, kye kyaviirako Sise okufa. N'olwekyo kubira Omulange eri bonna bikikwatako kuvaayo kuteekawo entegeka ennungi eri ffe abaana abawala okwesalirawo obulungi. Nalina mukwano gwange.
Come back from that. You had Sarah's story, and as sad as it is, this is the reality of what's happening in our country today. And so I do not want to even bore us even more with my own stories, because there are quite a number of stories in the room, online, and also with our panelists that they will share with us around what's happening in this country today. And I would like to invite our panel and introduce our panel to us today. First is Miss Gloria Lake. Gloria is the program officer at CIHAD, and she is very experienced in working around SRHR issues. Welcome to the panel, Gloria. Yes, you're welcome. You can just turn on your mic so that you don't have to keep turning them on and off. And then also on the panel, we have a beautiful young lady called Shivan. Shivan Alinda is a second-year law student at Makerere University. I know that so many people think that contraception is not for young people. You're supposed to only use contraceptives when you're married and what. So Shivan is going to let us in on how people her age are dealing with SRHR issues. And then we also have, Shivan, you're very welcome.
Thank you very much.
We also have Sheila. Sheila is the program director at GWAG. And Sheila is also representing the sex workers community. It's brave of you to even be sitting on the panel, so you're very welcome. I'm glad to have you today.
Thank you very much.
Yes, and then we have Dr. Chigundu. Dr. Chigundu is from the association, so forgive me if I can't pronounce this word, because in life, my English money was eaten by the teachers. So I shall just use the acronym. He's part of the Association of OBS and GYN. I hope we understand that. He will explain what that is, because I don't want to bite my tongue and then we have no moderator. So he also is the senior GYN at Mulago Hospital. And as you can see, our panel is very well experienced, and we're going to have fun today. Doctor, you're very welcome.
Thank you very much.
I will be introducing two other panelists as we go along, but for now we'll start with these and we will delve directly into our conversation. I'll start with Gloria. Gloria, Rose talked about so many things in her keynote address, and some of these things are alarming for the people viewing and for the people in the room today. Some people cannot believe we have that many abortions happening in Uganda, because we think that it's a hush-hush thing. And also she talked about the myths and the misconceptions around contraception. She talked about something to do with young people and the conception, their perspective on how they think about contraception. She has talked about so many things. And then she loaded us with statistics. So you're going to help us break down what the national perspective is, or what the national stand is right now on safe abortion or on abortion and SRHR. In like 5 minutes, just give us a brief overview.
Yes, please. Thank you so much, Penlo. I'm Lake Gloria. I think this has been noted. I'm a lawyer and a program officer from Center for Health, Human Rights and Development. Center for Health, Human Rights and Development basically provides for access to the right to health, and also the justiciability of the right to health, so that everyone in Uganda and East Africa overall can be able to get a portion of this right. We work through three
we work through 3 prongs, which has litigation, advocacy, and we also do research and knowledge management on so that we can be able to get these statistics that Rose was Wachikona was actually presenting on. Sex workers, when I talk about, this came out key for me because this is something that we keep on pretending that it's not happening, that sex work is not happening. During COVID, actually, it was a good thing because it came out as a reality that actually people are earning a living and this is their work. But then you find instances where sex workers are being arrested for basically going against the presidential directive of COVID-19 because their work, basically, most of them is during the night. So how do you help such people? Do you go ahead and you just arrest them and over some law, or do you find a way of alternatives? If or not, you find a way of protecting them. Because that's the most important thing. Someone has chosen unemployment, you find a way of protecting them in their employment and in the way that they earn a living. When we talk about mothers who are giving birth on the streets, COVID-19 brought out that reality. We kept on saying that, no, we have hospitals that are enough, our health facilities have everything. But the health workers were telling us otherwise. They were saying, yes, I want to help this woman, but there are no gloves. There is no gauze. How can I help this woman? So COVID-19, I can't say it's actually a good thing. I would say actually there are positives that came out. It brought our dirty laundry out there. And the government has to come out and say, yes, we have this problem. Because now they panicked. At the end of the day, COVID-19 brought a panic situation of, like they said, all of you go home, close the houses, stay home. Then they realized, oh, mothers have to give birth. You can't keep the baby until COVID goes away. So they had to devise means, which actually we appreciate the government for doing that. And we call upon, I think, more efforts in that line. And when it comes to health workers were always talking about these lived realities of unsafe abortions. And they would always be asking them, where are the statistics? Where are the women who are having these unsafe abortions? We are not seeing them. Basically, they wanted people to hold placards and move around and say, I've had an unsafe abortion. I'm here. Of course, you would get arrested. That's a bad idea. But they are there. So health workers were saying, please, let's try to find a way to help these women. And they were basically blind to that fact. Until I think most of you have seen the Facebook messages where a lady passed on a Facebook post. She passed on at her boyfriend's place, and actually there was no help. When statistics show the health, Dr. Chigundu will be able to advise more on this. I'm not a medical professional, but they say it's the safest procedure if done with a qualified or skilled health worker in a health facility or whichever place that can be called safe. For someone to die, it's a very, very miserable way to die. You are away from your parents, you are away from your loved ones. There is help, and you can't access that help. It was actually so sad. Of course, she was stigmatized, the boyfriend was stigmatized, but it's a reality. It's happening. Shivan will be able to tell you this, because these are the realities out there. So what are we doing to help these women and girls? We can't just turn a blind eye or a deaf ear and we say, no, this is not happening. Since I'm not seeing it, so it's not happening. I would as well say COVID is not happening because I can't see the disease flying around. Yeah. So actually we have to help, and we have to devise means to do that. When we talk about unsafe abortions, Ms. Wachikona was able to talk about comprehensive sexuality education. This is something that has been battled, the religious and what. All of us are saying, what is sex education? So long as someone hears the word sex, they say they are teaching people to have sex. Yes. The styles are the ones being taught. But no one bothers to go ahead and find out what is involved in sexuality education, sincerely. Because actually, if you went and found out what is involved, you would actually be interested. Actually, you'd hold a placard and support it. So teenage pregnancies. A girl is out there. It was all over the media. She's out there. And people are lying to this girl that if you go and pee after having sex, you go and have
sex standing up.
Yes. If we stand up, you won't have it. If you swallow aspirin, all these misconceptions. myths and all these lies. And this girl is there at home because schools are closed, and she's being deceived, maybe even by relatives. We have had cases of incest shoot up. But if girls are taught, or the boys are taught, all these children are taught that this is it. This is what happens when you have sex. The reality. This is what happens when you have sex. Your body, you have body autonomy. No one is supposed to touch your body. Whether it's your uncle, whether it's your mother, no one is supposed to touch your body without your consent. I think it's very, very important. When it comes to LGBTI, I think she talked about it. It was really, really, it also stood out for me because we saw instances where the police was storming shelters, and these people, they are not trying. People actually believe that LGBTI or whatever it is, it's contagious.
Yes, people think it's another pandemic, so we'll add it to the 4 that are already
that are already there. So people actually say that no, when you associate with people like who believe like this, or it's just, I would attribute it to ignorance because we don't take the time. Hear the word abortion. Not post, not care, nothing. Abortion is the key word. They don't find out anything. So this, if we could be able to sense, I would call upon like sensitization of police work, let me say law enforcement, basically, to be able to understand that PAC, post-abortion care, is legal, and actually everyone has a right to it. There is a need for access. When it comes to contraceptives, there is a need for access. They talked about the stockouts. The report came out, and there is a stockout of condoms, of IUDs, of Depo-Vera, the injector plan. And what are people supposed to use? And when someone gets an unplanned pregnancy, abortion is also illegal. You can't be able to. Basically, they are saying, be with your uterus. We don't care about your uterus. Deal with it. So if you're not giving someone any options out there, you're not helping that person in any kind of way, what is that person supposed to do? So maybe my call would be that we would try to make the law less ambiguous, because you find health workers are also confused. Should I give post-abortion care? Should I? Because you will be, some of them would really be arrested because people are not understanding. Some have been arrested, as I told you, humiliated around. So when they hear the word, you've come in, you're bleeding, what they want to avoid you. And yet this person, your core job in this world is actually to save lives. The duty is upon you to save lives. So I think they also need more protection, and comprehensive sexuality education should be actually shot up, especially during the lockdown, which is mostly needed for those people who are actually staying at home.
Okay.
Yes.
Thank you so much, Gloria. And I'll just jump to the doctor, because all the things that you talked about require some expert evidence right now. So, Doc, sorry, I'm calling you Doc. It's such a young people thing, but yeah, doctor. So Gloria raises a couple of issues. One, she talks about abortion in itself. What is this thing? What is this mystery in the room? Because there are people who are listening or watching us, and they're thinking, who are these mad people talking about killing people? Yeah? I just want you to highlight a bit. Is there a such thing as safe abortion? Does it exist, or is it a myth? And while you help us understand that, please talk a bit about access to SRHR services. From your experience as a doctor, I know that some of your colleagues have been arrested. I know that some of your colleagues shy away from giving post-abortion care. Some of them even fear and shy away from carrying out the procedure itself. Tell us a bit about your experience with SRHR, with an inkling to specifically abortion.
Well, thank you very much. I'll directly go to the questions that you have raised. And abortion. What is it? And I think people need to know that abortion is the ending of a pregnancy before the content, the product of conception, is able to survive independent of the mother's body. That's an abortion. The good ones want to call it a miscarriage, but it's still the same. The only difference is that some occur spontaneously, and they are called spontaneous abortions or spontaneous miscarriages, and others occur by induction. Then they are called induced abortions or induced miscarriages. If you are able to impregnate 100 women, we know that about 20 of them will spontaneously abort. So it is that common that 20% will spontaneously abort. But also we know in Uganda that about 16% of all pregnancies are actively induced and they are lost. The figures are high, they are there, but sometimes the figures don't give a good picture, but we know that we have had a rise in the last 10 years from 290,000 to 314,000. So there's a rise in this business. And the women that actually suffer are very many. Most of them suffer silently. But a few also die silently.
Yes.
And we know that sometimes even the families are scared or do not give the right cause of the death. Sometimes they also don't know what has killed their beautiful young girls. But we know we lose about 5 women or girls every day, every single day, from this type of abortions that we call unsafe.
Unsafe, yes.
And I think Rose gave a definition of what was unsafe. And in the context of the laws, stigma, ethics, and religion, most abortions are going to be unsafe because people even stigmatize the word abortion. And some people, even when you have been in a meeting and then you find they leave, so ask them what they have been discussing. Some of them will not talk, but they have been discussing abortion for fear. Access to services, to abortion services, let me begin with abortion services, have been hampered because of stigma and availability, service availability. I've seen women die from spontaneous abortions. Because they could not access care quickly, so they bleed and die. And why? Because some facilities do not provide post-abortion care services because they are not sure whether it is right or not right. But also some of them are not skilled enough to provide the services. So they keep referring, and by the time these poor women reach a center that can provide a service, sometimes we have lost a good number of them. For girls or young women, by the way, not only girls, anybody in reproductive age can actually get an unwanted pregnancy. I'm sure that some of you, if you missed your period now, you'll start praying very hard that it comes. Even you know that you really don't want to have a pregnancy that is
The
carried.
men
But
are
of course,
praying more for the period
stigma-
to come than the women.
yeah, some men. Actually, you know, we should talk about sex as I look at sex, but sex has many objectives.
Yes.
And different people may have, the partners in sex may have different objectives. Sometimes the male objective may be different from the counterpart's objective. So access is hampered because of stigma. Because I know in Uganda you can get a safe abortion service, but you know, accessing it, being able to go there, is also sort of stigmatizing. It is like you went to a clinic and then they say STI or STD room, and you don't want to be seen coming out of the STD room because it is of what? It is you wonder what is happening to you coming from an STD room. Also, the absence more of policies. For me, I think the law is malleable. People say the law is malleable. So if the policies and guidelines were thick, I think we would have better service access. But we now know that we don't have an active policy. We don't have guidelines that are a little bit confusing. Some people say they are there, others say they are not there. Others say if the old policy is not there, if the new policy is not there, you can use an old one. If that type of thing is also failing to access the service. But also the attitude of the providers.
Yes.
We are also part of the population. We have also come from certain mosques, we come from certain churches, and we ourselves sometimes are barriers to SRHR, service delivery.
Yes.
Of course, the S is a big thing, the SRHR, and sometimes it's confusing. And many people will say, I am a champion of SRHR. But when you start saying, let us discuss the S,
yes.
you say, no, you see the S, I can't, that one is a little bit complicated. Then you say, you're a champion of SRHR.
Yeah.
When you talk about sex, that sex should, because you see sex is very important in our existence. We are all here because two individuals, either forcefully or by agreement, decided to enter that pact. And we are all here and working hard because we want to look after the products of our conception that we are leaving behind.
Yes.
So it is very important. But we also know that sex can be abused, sex can be a tool of war, and you can get complications from sex. And I think people need to know that you can actually have sex and avoid a pregnancy. The science is there. But people say, no, for us, so they don't want to discuss sex. Then it comes to reproduction, which is the other one. It's also complicated.
Yes.
It's also complicated.
Also, people pick and choose what they want.
You get pregnant,
Right.
and then you have a health. You go through the process of pregnancy safely, and you deliver. I mean, we have seen women die. Women should not die from the process of reproduction.
Yes.
We know that about 18 die every day, every single day. I have not seen COVID killing 18 in a single day.
No.
Every single day, 18 women die in this country from reproduction. And we are saying we have many champions in reproduction. Are we really serious? I think there's a problem. Then, of course, the health, most people agree. When you talk about H, which is health, people agree. They say, okay, health, people should be healthy. But what type of health? They don't go the whole definition of health,
Yes.
which is mental, physical, psychological. If we are going to define that thing, you may find that some of us in this room may not
unhealthy.
really be healthy. So health becomes a... Now, of course, this thing is also complicated when we talk about rights.
Yes.
They are. Some people just fly away. So what is a right? Who is a right bearer? Should women have a right on their uterus? I think that's one of the biggest things.
The biggest contention actually is on rights, because
that's the biggest
sometimes
contention.
we feel that we should police other people's rights. Yeah.
You see, when you accept the R, it means you have removed the judgment.
Yes.
But some of us want to accept the R, but continue to be
With conditions.
conditional. You say it is your right, but no under these conditions. You see, then you are not provided. So this is it's a problem. The real words actually affect access because of the way people think about them. And even for planning purposes, if you want the Minister of Health and said, okay, this R, how have you planned for it? You may find that it's not there. But they are saying it SRHR. This S, how have you planned for it? The real issues. They will tell you we have antenatal care services. They will tell you we have built hospitals and put delivery beds. I mean, that's where that's what is probably going to be seen. And then they'll say we are putting health workers. Contraception. Contraception, we have suffered in this country. Just give you a little bit of history. That contraception was introduced the modern contraception was introduced in Uganda in 1954 by the Asian communities and the British which had come. So it was seen as a service for foreigners. And then later the civil servants began to enjoy. However, in 1972, family planning was banned in this country. It was banned. It was a political decision, just as there was a political decision that Asians should go.
Yes.
So it was banned. And now in 1982, it was being called back. So the banning of family planning or contraception meant that it could not be taught even in medical training institutions. So you find that we have a group of providers who were trained who never had a chance to train on contraception. Then after that, it sort of came up as a parallel program. We have health here, then we have, that's why when you visit some of these facilities, family planning commodities don't come through the NMS. Until recently, they were coming through to the districts, then the districts will distribute the facilities. So it meant therefore that if it is only the women, the providers, who were in the MCH clinic, who were now being taken for training to provide contraceptive services. So that limited access, and it still limits access to a number of these. Now, of course, we have been talking about even we as providers have attitudes against or for certain contraceptive methods. When you talk about the intrauterine contraceptive device, and you have a 15-year-old, some say, she's still too young to use that one. But also, we are also thinking, some of us are doing health work in contraception, but we are also parenting.
Yes.
You know, confusing these two. You find a girl of 14 comes for a contraceptive, say, for you are supposed to be in school. You know, we have been told in the keynote address that we are sexually active at the age of 14, most of us. And so it is the reality. And this information is gotten from the adults. They're asking them, when did you start? And they are saying, I started at 13, I started at 14. Now they don't want their 16-year-old to start.
Yeah, and Doctor, I will get back to you on that because I want you to talk about the undue burden on health workers. But let me quickly bring in Shivan because we are talking about young people now. And I know that the conversation is getting heated. For a very long time, I was shy to talk about sex because who talks about sex? The fact that you talk about it, you're having sex, it's a crime, it's one of those things. So Shivan, as a student and as a young person, what is the experience of young people? How are you accessing SRHR services, especially in this COVID time? But also, what are those attitudes? Because I specifically want to continue the conversation on attitudes, both of the health workers and also the attitudes of society towards young people accessing SRHR services.
Thank you very much, Penny. So, as rightly introduced, Alinda Shivan from Makerere University, School of Law. I'm in third year. I'm going to give an interesting story. So, when I got to Makerere University, I'm in Complex Hall. I get to school, I'm really excited.
You're my OG, I was in Complex Hall also.
I get to school, I'm excited, you know, law school at that. So my parents dropped me off, and that night, the boys from Mitchell Hall come over. It's time to, you know, have fun, party, and things like that. So, yeah, there's a lot of noise. Then later on in the night, I see the Minister for Health in the hall carrying a box of condoms and places them right in the middle, smack in the middle of the hall of residence. Now, I'm from a conservative family, conservative background, traditional Christian, and so I'm in shock. I'm like, what are you doing? Why are you putting these things in the middle of the hall?
You can't even name them.
I can't even. I was like, what? But 3 years down the road, I have come to realize that it is the norm. Yeah? And we're not going to pretend that young people are not sexually active. Statistics have it that 77% of Ugandan population is a young population, below 25 years. And Rose has rightly told us that sexual debut is at 14. So we have most of the Ugandans in the country sexually active. And we're all pretending like it's not happening. It doesn't make sense, yeah? I would like to use the analogy of we're just like ostriches burying our heads in the soil. Like, we don't see it, but it's happening. So, talking about the perspectives of young people from especially Makerere University, I'm going to draw it to the access to information.
Yes.
Yeah? There's very limited access to information. I would like to applaud the government that there's a framework in the pipeline on SRHR. And yes, they're going to do the teaching and everything like that. But as it stands right now, most of the things that people are going around saying are myths and misconceptions, as we have already had. So you're going to have two blind people trying to lead themselves. You know, someone is going to tell you, yesterday I had sex and I feel I'm pregnant, what should I do? Your friend is going to tell you, go and, Rose yesterday was telling us they used to tell them, go and wash your parts with Coca-Cola.
Yes.
And you will not get pregnant. Yeah? So I feel that there's a lot to be done, especially with young people, seeing as it is the biggest percentage in the country. The government and other stakeholders need to come up and do something and stop acting like it's not happening. And with health workers, they also need to understand the statistics, because statistics don't lie. So if as an 18-year-old, 17-year-old, 16-year-old comes into a facility and wants to buy a pregnancy test or wants to buy whatever they want to buy that is in relation to SRHR, don't look at them like, what are you going to do? Yeah? These things are happening.
Because I have friends at our big age, I shall not mention my age, but I have friends at our big age who cannot walk into a pharmacy and ask for condoms.
Exactly.
They cannot walk in and say, I want a morning after pill, because it's a shameful thing.
Yeah.
What are you doing? You're
Yes.
young. Why are you
Yes.
having sex? You're supposed to have sex in the institution of marriage.
Yeah.
And we forget about the reality that's happening around us, and I think that's really difficult for young people to even
Yes.
cope, because all this stereotyping keeps you hiding your head under the sun.
Exactly, and I was sharing at office yesterday. I am currently interning at SEHAD, and
Yes.
so we were discussing SRHR, and I was saying that now in relation to the realities of COVID-19, we were saying that during campus and on campus, you can go and get the government condoms that they provide in whole.
Yes.
But now, you're at home
with your parents,
with your parents
and
or
everyone.
relatives or alone, and you have to go either buy or, I don't know, you'll have to find a means, and you know, most people are not working. So it becomes very difficult. So the question of access also needs to be discussed in depth, especially for the youth.
Okay.
Yes.
Thank you so much. I will ask the doctor to talk a bit about the information part, because also I know that we can have access to the contraceptive methods, but we don't know how they work or how to use them, especially for young people. I know people who don't even know what a condom looks like. I was telling a friend of mine a few days ago that there are so many female condoms on the market, so many. But I can bet there are millions of women who don't even know what a female condom looks like. They've never tried it, they don't know how it, yeah. The men know, however. The men know how it looks like, they know how it works, but the women for whom it's made have no idea. So let me invite our last panelist for this segment, who is Sheila. Sheila, Gloria in her comments talked about the effects of the lockdown and the effects of curfew on sex workers. And I just want you to share a bit, just share a story. You don't even have to answer any question. Just share a story on what your experience has been like for your constituency in this time of COVID.
Thank you very much, Penny. I'm Sheila.
Sorry, I've been calling you Sheila.
No, it's fine.
Sheila.
It's the same. Yeah, it's the same. So I'm a proud sex worker, to say so. Young of age. As my colleagues have said, actually sex workers are one of the populations that are not even recognized in Uganda, actually worldwide. We are not recognized, we are not known. When you talk about SRHR services, these are the services that they are not given to sex workers. A sex worker cannot go to a facility to ask for family planning, abortion, what, because they are like, they don't feel comfortable asking for those services because they are discriminated, stigmatized. Yeah, so if I'm to tell a story, I have so many stories,
Just
beautiful
the juicy
stories.
one. The most juicy one, because the stories are very many.
A bit of a juicy story, actually, during this lockdown. As a young sex worker, as I'm working with an organization, Sex Work Led, so we had to go and give out SRHR services to the young sex workers. But you find, we found like the brothels, the lodges, they are all closed, and the government is not caring about this population because it's not recognized, as I said before. So we sat down, I sat down with one of them. Actually, she was even an underage young adolescent. She was 16 and she's a sex worker. She started sex work at the age of 13 years. And she was telling me a bit of her story. Like, when lockdown started, I think a client came and asked her for services and such. So the client raped the girl. So she got pregnant and she was asking me for services of abortion.
Yes.
So I referred that to Maristops, though I don't know so many people in Maristop, but I have their card and what. So she was telling me, but now you see, I can't even go to the police to file a case because even though like the peer went there to file a case, and I think the spokesperson was like, oh, you're a sex worker, and you've come to tell me that they've raped you. You're already a sex worker, so why are they raping you? So they even don't know that also sex workers are being harassed, raped, you know? So
and that's the thing the doctor was talking about, that we choose and pick. So we think that because I have a right and I'm not a sex worker, who are you to talk about your rights as a sex worker? You don't have any rights.
Yeah.
Some people think that because you've chosen sex work, you're prone to, you've allowed everything that comes with that line of work. It's like telling me I'm married, and therefore, because I'm married, my husband has the right to my body whenever he wants to. And that's just a very wrong perception. So Shayla, in terms of what your organization and yourself are doing about these complexities, because I know there are many. You've just talked about one or two or three, and there are so many. Please note that the conversation is going to keep on even after we get off the live broadcast. The conversation will keep happening online, so just keep those comments and the questions coming online. So in line with all the challenges that you're having, and especially the fact that you're a young sex worker, what are you guys doing about this situation? How are you trying to mitigate these challenges? Because it's difficult to work, especially in a space where abortion is criminalized. You have a ban on comprehensive sexuality education. You have all these things. You have an environment that does not support the work that you do. How are you peddling through these challenges?
Actually, as organizations, sex-led organizations, I'll talk about my own work. First and foremost, we advocate for sex workers, and advocating for these sex workers give them hope. We go on talking to them, we make documentaries, we talk to them, we provide SRHR services. However, because I'll tell you a scenario when I went to Kasenyi last week. I've never moved on water. That was my first time, but I had to give SRHR services to these sex workers very, very deep on the banks of Uganda. I even don't know because it was my first time to go there. So, and organizations also offer, we make DICs, so they come, we talk to them.
Please say DICs in full for people who don't know the acronym.
Actually, me too. I'm not so fond of a DIC that much.
Dropping
it's like a dropping
centers.
center. Yes, thank you. It's like a dropping center where sex workers come in groups to come and sit down and talk and give themselves stories like the one I've given in, like I am like giving.
It's like a fellowship.
Thank you very much for sex workers. And also another thing we do, we train sex workers. Like you said, some sex workers even don't know female condoms, but we do train them about different types of contraceptives. Yeah. So we are doing, then during the lockdown, we started doing social networking, that is SNS, which helps the positives because we have positive members.
Yes.
Yeah. So to make them at least feel more comfortable, we did as a community, they designed that to help them get their medicines and so that they can get their services right.
Okay, thank you so much. I'm going to just ask us to watch a short video, and while we watch that video, I'll invite our two other panelists, because I haven't forgotten about them. I promised you I'd bring them, so the two other panelists are coming up, and the conversation is getting juicier, so just grab a sip of water, don't run away, just stay tuned, and we will be back after the video.
Sky view, everything brand new with Orange Sky View. Orange Sky View, the sky is the limit. Everything brand new with Orange Sky View will cool you down under the hot sun. Everything brand new with Orange Sky View. And when you're feeling blue, refresh yourself. Quench your thirst if you're craving for the best. Sky View is your taste.
Refresh yourself with a cool, fantabulous Sky View. Sky View, go extreme. Sky View Orange is a product of the Reham family.
Akina Mamawa Africa, with support from Urgent Action Africa, will hold an e-conference this Tuesday, 29th September 2020, from 3 to 5 p.m. under the theme Illicit Financial Flows, plugging the outflow of resources for gender justice to facilitate public understanding and generate discourse on illicit financial flows in a bid to increase demands for accountability to stop the loss of resources critical for achieving development outcomes, particularly gender justice. The e-conference will focus on raising awareness on what IFFs are, how they manifest, and how the global financial architecture enables the loss of resources. Panelists include Ms. Eunice Musime, Executive Director, Akina Mamawa Africa, Mr. Sydney Asubo, Executive Director, Financial Intelligence Authority, Ms. Leah Irienyu, Research Advocacy.
Televisa presents
has been grabbed by community, by their parents, by their relatives, by everybody around them. And how did that end?
Okay, thank you, Penny. I've been introduced. My name is Loretta, or we know Oken. And just to answer what you've asked, I'll just give you a brief story to give you so that it can take us to where I'm going.
Sure.
In Bujiri, where we implement, UCOBAC implements, we have a project running in Bujiri. It's a project for prevention, education, empowerment, and recovery from SGBV, which is sexual and gender-based violence. We partner with the hospitals, the district hospital, and several clinics around Bujiri district. Now, during COVID, we got a case where a young girl, 15 years of age, let's call her Mary, went to the clinic. She was taken to the clinic by her mom, to the hospital rather, the district hospital, by her mother, because she was not feeling well. Now, on reaching the hospital, they kept checking, and she kept saying she thinks she has malaria. They're checking and testing for malaria, testing for bacterial infection. There's nothing that seems to be coming up. So one of the health custodians talked to the mom and told her, let me counsel and talk to your child while you're not around. They talked to her, and she opened up and told them that, well, the pain she's feeling is because she had tried to carry out an abortion. And she went on to disclose that it wasn't the first time it's happened, it's the third time it's happening. It's just that the first 2 times it went on well, so she doesn't know why she's here because of that. So after that, the hospital went into treatment mode. Unfortunately, the hospital did not have the drugs to help her with her post-abortion care, which is supposed to be there because it's legally mandated. They're mandated to provide post-abortion care, but they did not have the drugs. So they had to refer her to one of the private clinics that we work with. Now that's how UCOBAC got to know about the girl. So the private hospital calls us and tells us we have this case. The girl has tried to expel fetus, and there were no drugs in the main hospital. We have the medicine, but it's at a cost. So should we treat her?
And
So
I'm
we
sure
said,
they couldn't afford it.
yeah, they could not afford it. They said, should we treat her? Because they don't have the money to pay, but she needs the medical attention.
Care, yes.
So we said, there's no debate there. How, no matter the cost, life first, then you cater for the costs after. So I said, go ahead and start treating. UCOBAC will cater for the costs. So they start treatment. Unfortunately, maybe it had taken a period of 2 weeks in between up and down of not getting medication. So in the process, she's getting septic. So her legs start swelling. She's on treatment, but her legs start swelling. Her body starts swelling. Her uterus starts oozing out pus.
Oh dear.
And 2.5 days later, she passes on. So when you look at such a story and you say, this 15-year-old girl who's come with her mom, and she told the counselor that she used some herbs, she's come with her mom, she told the counselor she could not tell the mom.
Yeah, because the mom thought it was malaria.
Yes, because the mom thought it was malaria. She feared to speak out, feared the judgment she'd get from the community, castigation.
Yes.
You like, I am 15 years old. First of all, they'll tell me I'm 15 years old. What are you even doing being sexually active at 15? So she's fearing to come in front to tell the mom of the problem. She's fearing to talk to the counselor until probing happens, and then she speaks up. And then, unfortunately, after all this, then she dies. So it's it clearly shows that as a girl, the rights part comes in. She's a human being, but her rights of her health rights, from the hospital not having medicine, from her having to hide all this and not speaking up because I have a problem but I can't tell anyone, all these are rights being hidden and being abused. Her rights were not, she did not get to exert her rights. So when it comes to bodily autonomy, that is a debate that can take another session. Because in Uganda, we've signed and ratified the the Declaration of Human Rights, and we say we are for human rights for everyone. But I think it picks out and says you can have the right to medical attention, you can have the right to legal representation, but then when you go deep down, the rights that are under that medical attention, some things are left out, which means that the bodily autonomy is not really, you don't get to celebrate your right to bodily autonomy.
Yes. Oh dear, and I know that I don't even know how you work in a community that interfaces with such challenges. It breaks my heart that a 15-year-old loses their life hiding an abortion. It shouldn't be like that. So one, I want to commend UCOBAC for even coming up with some interventions for the community. But also to just ask you just a follow-up question. You mentioned paying for the services, the post-care abortion services. What happens when you can't pay? and I know that the answer is obviously death, but I know and I know that there are very many people out there who don't even know the existence of an organization like yours, or who don't have access to friends who can pay for these services. What can be done? What can be done to ease that process? Is it an issue of information? Is it an issue of money? Is it an issue of, what is it exactly?
I think it's an issue of information. she mentioned it, access to information. It starts from the beginning, because it's not someone just falling out of heaven and saying she's pregnant.
Yeah.
It's all about, they mentioned the sexuality education. If it starts from that, not just in school, but out of school, sensitizing the communities about what sexuality education is. We're not telling people go and have sex. We're telling them that you need to know about what falls under sexuality education.
But you see, you're talking to a community that has been raised, so our parents and our great-grandparents were raised to only to whisper about sex, not even talk about it. You cannot talk about it. You whisper about it in the confines of a safety of a senga or an elder, or when you're getting married, or so you have a community that has that perspective. And then you have all the reality that shows that people are having sex as early as 14. So how do we draw the balance? Because the moment you bring up the conversation, you're saying you're teaching our children to have sex, you're teaching them bad manners. You're evil women, you're not going to heaven, you're going to see hell. God forbid that you die today. The devil is coming for you. So
well, I think
how do we balance that?
It's something that is gradual. It's an attitudinal thing. Attitude takes time. You cannot come and say, well, I'm teaching you today. You have to listen. You have to learn. And it stops now. You'll accept your children to do as they please, or you listen to your children if they come to you about this and that problem. No, it takes time. That's why SEHAD, you go back, Mary Stops, different organizations exist working towards changing people's attitudes. We cannot do it all at once. It will take time. Even the Ministry of Health and Ministry of Education coming to the back and forth ping pong game of the sexuality education framework, where it's there, then they pull it back, then it's there. It's a matter of people accepting, then others being, but at some point, I believe, once we keep teaching and giving information about rights, about bodily independence, I think it will change. It's not an immediate thing, obviously, that we have to agree.
Thank you.
I believe it will.
I will ask Shivan to talk a bit about changing the narrative, but before I get to Shivan, let's hear from Grace. So Grace, you had Mary's story. We called her Mary. You had Mary's story, and Mary's biggest problem was she had no one to go to. She had nowhere to go. And here you are creating safe spaces for women to talk about, to receive post-abortion care, or to receive care while they're undergoing the process of deciding whether to keep or not keep the baby or the fetus. Please share with me how that has been for you in this COVID-19 period.
Thank you so much. My name is Choncha Barbara Grace to the agenda.
Just turn on your mic down there.
Are you okay? All right. Thank you. My name is Choncha Barbara Grace to the agenda. I'm a feminist, stroke activist, but by professional, I'm an accountant. You may ask me why I'm here. I've been challenged, I've been getting challenges in my life, the challenges of maternal health and abortion inclusive. That's why I'm with you people here. And at Target Uganda, we are advocating for sexual reproductive health rights, mainly safe abortion.
Yes.
Yeah, to go back to your question, it is a bit complicated, but we have been doing this we have problems. When I tell you the stories that we have gathered at Target Uganda of unsafe abortion, it is really, really alarming. At Target Uganda, we have been reaching these women who have had an abortion or abortions. You know, women can have more than one abortion because women, we have a lot of problems, challenges. So, as she said, what we do at Target Uganda, before COVID, we have been reaching these women through dialogues, workshops, and other sorts of meetings. Like in the dialogues, we have been forming sessions where we have women who have had abortions and women who are intending to terminate their pregnancies. And you know, a problem that these women are facing, when they get pregnant, they feel they should terminate it, but they have got stigma that really disturbs them always. They are not, they cannot share their experience. They cannot even talk about it. Not until we gather like the way we are here and they are able to speak up.
To share their experiences.
Exactly. That's what we have been normally doing. And women have managed to share their experiences. And their experiences are tough. Where these women have lost their uteruses. Some have died. Their relatives have died. So mainly that is how we deal with these women.
Yeah, so I hear that you collect the women and have dialogues.
Yes.
How has the dialogue been happening now during the COVID, since you're not able to meet?
Thank you. During the time like COVID now, we have been reaching women through online. We have got our free telephone line where we share with women.
So you have a toll-free
Yes, we have a toll-free number.
Okay.
Yeah, where these women call and we share with them. We have counselors at Target Uganda who first counsel those women in need or seeking for abortion. And then when they are prepared, we refer them to medical practitioners. That's what we normally do at Target Uganda.
Okay, thank you so much. For those of you who are watching us and you're probably wondering, how do I get the toll-free line? We're going to share it on the CIHAD social media platforms, so you can reach out, but you can also reach out to CIHAD and they can recommend where you can go to have more conversations on abortion and post-abortion care. I'll go to Shiva now. I want you to talk about a bit on how we change the narrative, especially from the young people's perspective, because sometimes we think that, schooling is done the same way for everybody. So just share how you think, in like 2 sentences, how you think we can reshape the narrative around access to SRHR services.
Okay, so I'm going to start from making the point that SRHR information in general is not new. Yeah? I feel people are scared. Maybe it's the term SRHR that scares people. But these are these are things that have been talked about. I remember growing up, there's something in the newspapers called Straight Talk.
Straight Talk, yes. We all grew up in the Straight Talk.
Straight Talk.
Era. Okay,
I'm as old as Straight Talk. So, yeah, Straight Talk had SRHR information.
Yes.
And people as young as 10 are reading Straight Talk. Yeah. People would put in their stories. Little child of 8 years is asking questions. Yes. So the public, first of all, needs to understand these are not new things. Yeah, your parents would buy you Straight Talk and give it to you. They would buy newspapers and let you read Straight Talk. So what has changed? Yeah. So understanding, first of all, that this is not something scary. Yes. This is something normal that is happening, and we need to embrace that truth. That the government and other stakeholders need to own their truth. Yeah. And understanding that you cannot work in isolation. Yeah. The organizations, CIHAD, and other organizations that are working towards SRHR are not bored because of COVID-19, and no, it's because these are urgent things that have. In that keynote, they said that when pandemics come, they take precedence over other things, but other things remain relevant and they are there. So that's how we change the narrative, understanding that these things have been there and they need to be addressed. We can't just sweep them under the carpet. Yes.
Nice. Thank you so much, Shiva. Now, Loretta, I want, so I hear what Shivan is saying. The information is there, and it's been there for a very long time, and we can just, you know, sexy it up a bit and make it more relevant to today's age groups. How do we get the people of the big age? Because now we've had the young people's perspective. So the people with a big age like mine, who have already been schooled and we know a certain thing, this is how it should be. From Adam, that's how it should be, that's how we shall die, and that's it. Young people should not have sex until they're in the institution of marriage. I shall not listen to you whether you have statistics or not. How do we help adults unlearn certain things in order to open up the space for information to penetrate this generation?
Okay, I think one thing is, she had mentioned it, dialoguing with them. When you're dialoguing, you create different age groups so that we don't mix the bazays with the teens who might make the situation uncomfortable.
Yes.
Another thing is, well, this thing of abortion, and when you say, sorry, you say trying to understand, trying to understand abortion as an adult is something that we also, as adults, when we were children, were as closed-minded as the adults are now. But we've come through the conversations, having conversations with the like-minded organizations, having meetings, having trainings, which we're still doing with the communities. I'll talk about the community, the rural people, the adults in the rural community who are worse than the adults in the towns, who are more closed-minded, engaging with them and letting them know that this can happen to anyone, using referrals of my child, my sister, my friend as an example. You know, if we start with those who are close to us, it kind of opens up your mind and it makes you say, well, if it's happening to Nalongo's children, and Nalongo's child has died because of this, it could happen to mine, and mine could also suffer the same consequences. So by talking to each other and learning from each other's experiences, I think it's a way of opening up each other's minds, because that's how some of us have come to learn that abortion or expulsion of fetuses is something that you should not be rebuked for, just because you've decided that maybe I'm not ready to have children, or it's not yet the time for me to do this. And I think, just to take it back, if we're trying to reduce on the talk of abortion as an issue, we'll take it back to the access to information and talk about teenage pregnancies. How can we prevent this from happening? How can we teach our children that this is when you and the boy come together, this will happen? It's up to us, the parents, still. Now, if you give them the role of, it is your role to do this, don't you think then your daughter, who you've informed about this, chances are she might not have to.
Sorry, that was not a bomb. We are safe. So breathe. And as we breathe, I'll save the doctor for last, because I want him to talk a bit more about two things. One is the attitudes. You mentioned the attitudes of the health workers, and I just want you to help our audience understand what we can do to both help the health workers be more empathetic. I think that's the word. To be a bit more empathetic and understanding, but also how do we unlearn? How do we help health workers unlearn? Or how do we as health workers unlearn the things that we have been taught? You gave us the history of contraceptives and how, you know, we had to do away with contraceptives and then brought back. So some people are still stuck in that era. How do we move on with the trends that are happening today? How do we become alive to the realities that we are living today? And then secondly, what is your advice on demystifying the myths around SRHR? because you mentioned the different parts. Some people want to talk about sex, but even in talking about sex, I'm Penny, I can talk about sex boldly and ably. When we talk about eroticism and sexual pleasure, no. I can't have a conversation around that. I want to talk about reproduction, so I will talk about menstruation, I'll talk about all these other things, but when it comes to certain contentious issues around reproduction or reproductive health, I don't want to go there. How do we become advocates of the entire spectrum of SRHR and not get to pick and choose?
Well, thank you very much. Attitudes, they are difficult to change, but they can. And we have seen it when we begin with the stories, and we go to try to do what we call values clarification. Understand we begin to understand people and why you are thinking like that, why you're taking a decision, why you're thinking like that, and also identify that different people have different values.
Yes.
We look at the same thing differently, and that therefore you should, when somebody is in front of you, just to recognize that they actually have a different value than what you are having. And therefore it is, as they are not imposing their values on you, I think it's also not right for you to impose your values onto them. It takes time, but I think it can actually do the work it has done some of the work for some of us. In our traditional training institutions, attitudes were never taught. We sort of learn on the job. I'm telling you that even greeting a client or greeting a patient was never taught. So if you know how to greet them, you greet. If you don't know, if you think it is not okay, you don't greet.
Yeah.
So even this thing called counseling, now we are talking about counseling, there are even degrees now in counseling. But before that, counseling and basic communication was never taught in these training institutions. So they'll come and teach you the terrible stuff, the hard stuff, and then they hope that you get these other soft skills as you go on. Fortunately, this is changing. We are having a course in sociology in medical school now, and we are hoping that we are going to improve the content on some of these, like that the health workers that come out also have learned these social skills that they can actually discuss. Now, demystifying, there are so many myths about almost everything. Even now, COVID, people say it is not there.
Yes. COVID is a government plan to rob us.
Or COVID was manufactured. So, I mean, there are so many things that when the manufacturer gets there, what they want, then they will call it back.
Yes.
So there are so many myths, but we need to understand. I think we need to be able to understand. Talk to ourselves first, as adults. And really remember, because we also went through these ages, and we saw the challenges. It's except that we are trying to hide the challenges we actually saw. And we are telling people that these things do not actually take place. By start giving wrong information. The first wrong information I've seen in some of the schools when they are putting these some notes in the compound. They're still telling people that sex is a sin. And yet that is not correct. Sex is actually not a sin. Actually, sex is not bad. So we need to tell them, we need to frame the questions a little bit differently, to be closer to the truth. That, if somebody had told me that when you grow up, you'll have sex until you get tired. Because now I'm telling you seriously, I sometimes look at my wife and smile. But when I was young, energetic, I mean, there was that feeling that, I'm stealing something that is not meant for me. So whenever you hide something, people, especially the young ones, try to uncover it and see what is this thing that these people are doing. The same with reproductive health as a concept is not very old.
Yes.
So it tells you how far the world has been, very far from the realities. But we have been reproducing since Adam and Eve. But we have never talked about this thing about reproduction. So it means that, yes, I think there's a general attempt to get out of this. We just need to have a concerted effort to demystify. But before you demystify, you must know the truth. And the onus is on us to get correct information and communicate it. But also we need to understand where the people are coming from. I've had a chance to go to have an audience with religious leaders, and we're talking about abortion. So somebody told me, why don't you call it something else? Otherwise those people may not come. But I said,
what else can you call it?
I don't want to tell them a lie, because when you begin from the lie side, they might disappear. So I said that we're going to talk about abortion as it is and get their views. I was scared. I thought they would chase me away. But fortunately, actually, they gave even more time because they were now inquisitive about things. We have been saying abortion is a sin or is bad. But we are seeing our girls die. We are seeing women die. Actually, we have now begun to see a group of women that are above 40 years die from complications of unsafely performed abortion. So it's not only the girls down there, but also the women who have lived through this. They have their 5 children, and then they discover they have a pregnancy that is unacceptable. You see, your husband is a Muchiga, you are also Muchiga, and you are scared of delivering a half caste who might be Indian half. And then you say, I think, let me get rid of this pregnancy. So we also need to be able to say what is the right thing in SRHR. Where should we go? I mean, instead of talking continuously of unsafe abortion, we have tried to say, but why shouldn't we talk about safe abortion? Why should also be delivering the negative? Isn't there a positive? And I think there are many positives that may make people begin to understand that actually there is an alternative to unsafe abortion. And that is called safe abortion. It's available and it can be obtained. Now we are getting a lot of information on which can help somebody in the community access a safe abortion. What we need to do is not throttle it, but rather to open it up, such that people begin to know, especially the where can we access this service, and then how can we use this service. Because you see, these girls are using knitting needles, they are using big pens, they are using bed springs to injure their organs to have an abortion. Now, if they have access to safe medications, which we have actually, they should be able to. So we should look at that and also demystify the fact that young people, in reproductive health, there's this age we call young because we are counting numbers. But when you begin to ovulate, we cannot be considered young anymore physiologically. So you have reached there. Instead of counting years, we really need to count functions of the body. Otherwise, why should have God made you say, if you are young, you should not be ovulating? Say that you wait until you begin ovulating at 18. No. You are ovulating. Some are actually ovulating as low as 10 years. They're beginning to show signs that they are mature. So we need to put that forward instead of putting the age forward. Because that would tell people that actually this person you're calling young in age is actually not young reproductively. So if you want to help them, please help them in that environment. Of course, the last one, how do you demystify the rights issue? Say right. I attended the meeting. It was hosted by SEHAD, and one of the board members complained that why did you say let us begin with a word of prayer? Did you think that everybody wanted to pray? Or did you think that everybody wanted to pray Christ? Because there are other religions. Said that you should have said, if you thought that you are so heavy on you say, let us have a moment of meditation. Each of you, if you want to meditate a tree, it's okay to you. If you think for you it is not religion, it is okay. So the message he was bringing forward is that you cannot talk about a right about a right, and then you impose. And I think, to me, that was a very big lesson that I learned. Once you say you are looking at rights, then you should not say what they are doing is wrong. Because then you are not, you know, by the time that you say it's not easy to accept right, but accept right, you must lose something.
Yes.
You must lose something, such that the other people can enjoy their rights.
Thank you so much, Doctor. And for those of you who are just joining us, we are coming almost to the close of this dialogue. Remember, we are commemorating the Day of Safe and Legal Abortions, and we are sharing experiences of the lived realities of women during COVID-19. I'm going to take 2 questions, just 2, and then we will close the online broadcast. We will close the live broadcast, but we will continue this engagement online. 2 quick questions, if you're there and you have 2 quick. There's a gentleman at the back, since they said we should engage men more. We will take the gentleman over there and the lady here. Sorry, I can only take 2. Please ask your questions online and we will have them responded to by the panelists. Remember also that these are not the only panelists. We have 2 more that we started with. So address all your questions to all the 6 panelists that we've had today, plus our keynote speaker.
Okay, thank you so much. And thank you, the presenters. Sorry, the panelists. My name is Joel Sendi. I work with the Uganda Youth Alliance for Family Planning and Adolescent Health, and also a co-chair, governing board right here, right now. My question goes to Dr. Chigundu. I've had a lot of young girls and adolescent girls who are getting information from the quack doctors. And then, I think in my mind, it's really important to have these quack doctors oriented to be part of the system, because if you are to look at the referral mechanism being strengthened, we should look at also the quack doctors being trained, at least to provide the information, and then in the long run, they refer the young girls to the doctors. Thank you.
Oh, thank you very much for that important question. We know that we get sex is mostly done in communities. It is not done at health centers or at hospitals. Also, pregnancies are performed there. So I think we need to move there. The traditional training system for medical workers did not embrace those people. And I think we need to now begin to move to embrace those people. We have tried as an association. I didn't tell you that I'm a member of the Association of Obstetricians and Gynecologists of Uganda, and we have what we're calling a safe abortion advocacy project. That partly is also targeting the traditional healers, the traditional birth attendants, and even the people who work with the spirits, those people who can say, go and you go. So we are working with them. We are having a good interaction. One thing that we recognize that they tell us that actually those people go to them for advice, and they don't know what to do with them. And they're also scared about referring them because they don't want to be considered as people that are actually doing. Actually, some of them even perform the abortions. Others tell you that they tie the pregnancy. They can tie the pregnancy for 9 months and then they release it at a certain age. So it is a small thing in the ocean, but we have begun an attempt to actually sensitize these people and get good information. The other thing that we actually probably need to improve is the working relationship between them and the line healthcare system in this country.
Thank you so much. Doctor, 1 minute, my dear. Your 1 minute question.
Thank you all for joining us to commemorate this important day. My name is Labila Smaya, a reproductive lawyer and a feminist. My question goes to Sheila and everyone providing these services and advocacy. How are you keeping your clients safe through the toll-free line? If we are to talk about the privacy and how the government can penetrate into your data, how are you ensuring their privacy and safety? Thank you.
Thank you very much. Straight to the question, our privacy for the clients is 100%, because even though we are providing the SRHR services, we make sure we protect their personality and confidentiality. Yes. So we protect it, and we have not yet got any client that is complaining about disclosing their
data.
Yeah. So it's 100%. And to the government, as I told you, we are the population that is not recognized at all. So we are fighting for ourselves. We are fighting for sex workers that cannot talk. Voices, we are voices for those who can't talk. So that's all I can say.
Okay, thank you so much. I would like to thank our audience online for staying with us and keeping online and asking those questions, sending all those comments. I want to just highlight 3 things. School yourselves. School yourselves. Get as much information as you possibly can. Do not be the clueless person who's just doing clueless things around SRHR. Be a scholar.